Good morning, ladies and gentlemen, and welcome to the third annual Child Health Technology Conference 2023. It's great to be back after two previous very successful conferences. And this conference, the lineup is as good as the two previous ones. We've had a great breakfast seminar already. Two great speakers, Liz Ashell-Payne and Timothy Chu. And I would encourage you, if you didn't go to the breakfast seminar, to go back and listen to them both presenting. And the theme of our conference this year builds on last year's aim of bringing together colleagues from across the globe to support the development of child healthcare technology. And the theme is building a global child health technology community. We continue on our mission to bring everybody together across the globe to focus on improving the health and healthcare of children and young people through technology development. Our conference has been made possible by our gold sponsor, Merck, and our silver sponsor, the NIHR Clinical Research Network, Yorkshire and Humber, and our silver partner, Innovate UK. And I would also like to thank our bronze sponsors, Health Innovation, Yorkshire and Humber, Helicon Health, Medipex, and Sheffield Hallam University Health Research Institute. So before we start our first presentation, I would like to remind you about our interacting networking Padlet platform. This is a new platform that's been brought to the Child Health Technology Conference that allows you to post a bio, to introduce yourself, and to interact with other delegates. No account setup is required for that, but delegates will have received a how-to guide for the Padlet in their email. So it's a good opportunity to network with colleagues across the globe in the field of child health technology. So ladies and gentlemen, it gives me great pleasure to introduce our first talk of the day of the main conference. This is a keynote presentation as part of the mind-body integration theme. This will consist of a pre-recorded talk, but please don't forget to submit any thoughts and comments about the session through our portal. And you can also do this for social media using the hashtag CHT 2023. So I'd like to now introduce our speaker. That's Dr. Anna Moore. Anna is Assistant Professor in Child Psychiatry and Medical Informatics at the University of Cambridge in the United Kingdom. And Anna will speak about the title of her talk, which is Towards Personalised Preventative Pathways for Children's Mental Health. Thank you, Anna, and welcome to the conference.
So hello, my name is Anna Moore. I'm an assistant professor in child psychiatry and medical informatics at the University of Cambridge. And today I'm going to talk about the work we're doing here to develop personalised preventative pathways for child mental health. So I'm going to speak about the theory, some of the practical infrastructure we're building in order to make these pathways a clinical reality in the future. But first of all, why do we urgently need this in psychiatry? So we currently have a mental health crisis in our children. Globally, 4 of the top 10 medical disabilities are psychiatric, and the prevalence continues to rise. So here in the UK, it's the same picture. So since 2017, the rates of disorder of 19 to 17-year-olds have steadily risen from around 10% to 25% in 2022. And there's no indication that this pattern is slowing down. Partly, this is due to COVID, but additionally, there are thoughts that it's related to the rise in digital and social media, and also stresses at school and the education system. But if we're really honest, a lot of the causes just remain unknown. So if we look at the rates here in younger children, so here you can see compared to the figures that we've just seen, these are the figures we've just seen, but just in a different graph format, the rates are also increasing. You can see here that the rise in 2022 was slightly less sharp in this age group compared to teenagers. But if we also look at the breakdown of these figures in different underserved groups, then we know that the most vulnerable in society suffer most, and they are least able to access help. And that includes those with protected characteristics, but also those who are not traditionally included in these cohorts. So, for example, if we think about kids in social care, data for these children is really terribly poor, but they in particular really struggle to access mental health services. Yet we know that almost all these children suffer from significant mental distress, and many as 75% have a diagnosable condition. So despite knowing about these high levels of need, we're actually really bad at identifying these problems in young people and getting them access to help. So if we look here at the pattern of contacts with professionals for mental health reasons, only around 25% of those contacts with specialists who have got the skills able to effectively identify mental health problems. And the rest are with professionals who know the children really, really well, but they're just not trained to effectively identify and signpost to appropriate help without mental health professional support. So currently we see that the burden of this responsibility for identification really lies with those people who don't have the required specialist knowledge or experience to identify problems accurately. So that's teachers, social workers, GPs. So they're fantastic with the children, but just not mental health specialists. So as a result, there's this real inconsistency in identification that leads to significant unwarranted variation. So on one hand, many patients with suspected mental health problems get referred to specialist services for assessment, but on the other hand, there's really important groups who just consistently get missed. And we can see this reflected in the referral rates and waiting times. Services absolutely cannot meet the demand created by these high levels of referrals into specialist care and assessment. And that's really the only place that most children can access a formal mental health assessment. And the referrals are on all-time highs. So you can see here that it's very small type. In 2019, we had about 60,000, and it's now more than doubled that by 2022. And the capacity to do this assessment and diagnosis can't be met. So the budget hasn't been increased to reflect the demand. And we've also got real problems in recruiting into the child mental health workforce. So 16% of community CAMS posts are vacant and nearly a quarter in inpatient units. So we just can't fill them. So this means that the threshold for getting help is increasing and children needing to get more unwell and to meet the criteria to help. And so only those with very high levels of need or those who are really able to effectively raise alarm within the system are able to get help. So in some regions, we know that the waiting list for routine care, for example, for ADHD assessment, is going to be more than 3 years. And I've heard numbers which are higher. So this means, when we boil this down, that over 70% of children who have a mental health problem, which is diagnosable, don't receive any support for that health at all, their mental health at all. This isn't an early intervention system, it's a late intervention service, if we can really call it a service at all. So to address this, we need to really urgently rethink how we're providing mental health services for children and young people, and developing digital tools that are integrated into the clinical pathway, which is designed for early identification and prevention, is one way to do this. It enables us to create a more systematic way to identify and quantify need, which at the moment is just not possible. So it's feasible, and in my talk I'm going to make the case for that today, but currently we don't have the infrastructure to enable it, the AI models, or the understanding of the ethics of how best to approach this. And it's really critical that we've got to work closely with the public and clinicians to develop the novel pathways and to evaluate them. So the next thing we need to think about are what are the opportunities for personalised prevention and early intervention, and what would this pathway look like? So they're very similar to those for any chronic physical health condition. So firstly, we need to be able to identify and intervene in those who are at high risk of getting a problem. We need early diagnostic tools that can, and we need to be able to diagnose systematically and effectively and consistently. And that might include targeted screening for those at high risk in settings outside specialist services. So for example, in the community and in schools. For those who we do identify, we need to be able to signpost them to the most suitable evidence-based services. We need interventions for children that are in the early stages of diseases, as well as those who are more severely affected. And children and families need to be able to be involved in decisions about the modality and the type of care they're receiving. And for those who do require interventions, we need to know which of the multitude of interventions is going to be most useful. And that's when we think about pharmaceutical options, as well as psychological therapies, or the combination of both. So we need to avoid severe adverse effects, and that's both pharmacologically and therapeutically, as well as recognising who are at risk of things like metabolic syndrome. For those who are at medium long-term psychotropics is indicated. And then finally, we really need to be able to identify those who are going to go into relapse early. And another critical thing is that across each of these points in the pathway, we absolutely need to be able to quantify the need so that services can plan and carry out research to develop effective interventions. So, and in particular, aimed at prevention and early intervention. At the moment, there's absolutely no useful data available on a child mental health need, and very little evidence base for what's effective for early intervention. And that's purely because we've been really bad at taking a proactive approach. We don't have the data, and we haven't been able to identify, and we haven't carried out many trials for this. So critical to this is a requirement for good quality data relating to CAMHS, and it's such a priority that at the moment is one of NHS England's top strategic priorities. So I'm going to propose that one of the key opportunities we have is the use of digital tools that can support each of these stages for the pathway and enable us to make personalised early intervention and eventually move towards a preventative system. So by innovating these artificial intelligence and machine learning driven prediction tools, we've got the opportunity to create a systematic approach to identification, signposting and towards management. And we can create tools that can be used in the community by non-professionals, which really reduces the burden on specialist services and getting children into care, the right care much sooner. But the question we have to answer then is, how do we do that? So to date, we find that single disciplinary research has really not been effective in tackling the issues. However, if we look at the evidence that describes the mechanisms for developing poor mental health, it's really rapidly evolving, and it reveals the role of genetics, immunology, inflammation, gut health, and neurology. And we can see here in this recent publication, or figure from it, in a Nature Review Genetics, that there is a really broad range of factors that interplay to cause pretty much all non-communicable disease, as well as impact on the course and susceptibility to treatment. But more specifically, child mental health, it's perhaps even more critical that we include consideration of these wider determinants of health. So, for example, we know that prevalence is hugely affected by social factors. For example, if we look at maltreatment, that increases the likelihood of mental disorder by as much as 30%. So we really need to understand how biological factors interact with these early life experiences and the environment, and we need to be able to do that across really diverse populations. So to address this, we need large representative data sets, which include multi-domain data that help us understand how the risk factors come together to create resilience and susceptibility. And if we can do that, it's got enormous strategic implications for child predicting and preventing child mental health problems using AI and machine learning. But it's really critical that they are translated in part of an integrated system for child mental health support, and they need to be fair and equitable for all, because we can't worsen inequality or outcomes for the most vulnerable. So the big question is, how feasible is this approach? So hundreds of predictive tools now have been created to try and tackle these issues for mental health. So systematic reviews highlight our ability to diagnose mental health problems ranging from autistic spectrum disorder to schizophrenia, depression. We can create models which have got really good performance, so in particular disorders where there's clear trajectories for disease. For example, neurologically based disorders like dementia, where we can reach performance of areas under the curve in the high 90s. Arguably less convenient for paediatrics, but even if we look at mental health disorders in children, we're better at predicting things which are clear neurobiological basis, for example, like autistic spectrum disorders or schizophrenias, where we can reach performance in the high 70s and 80s, depending on the type of data used. And this tends to be when we've got more clearly described and diagnosed disorders with much clearer biological features, where we're predicting precisely measured outcomes using well-characterized predictors. So we can also predict who will respond to treatment or not for some groups. So, for example, the preferred psychotropics, therapeutics, predicting relapse. And interestingly, there's loads of work now that looks at wearable data. So, for example, data also collected by mobile phones and social media. So things like tone of voice, a rate of body movement, how much we travel and sleep, our interaction with social media, and more specifically how those change over time can all be used really usefully to help spot changes in status of mental health. And finally, with the increased use of electronic health record data and its linkage, there's this really growing interest in using the data for predictive models. There's been moderate success in using this approach because there's much bigger difficulties here with data quality, and performance therefore is normally around 0.7, which is currently insufficient for clinical use. So although the field shows really great promise, we have almost no models which have got sufficient performance for use in clinical settings, and absolutely none that have been translated yet for clinical use. And that's because the current infrastructure we have can't support it. So either we can build these really accurate models, but the data is very carefully curated for research and that's not available routinely for clinical settings, or we have data that's used in clinical settings, but it's not accurate enough or sufficient in its breadth in order to create a tool that can be used clinically. So what we really need is to bring this data together into a system that's linked into clinical systems so that we can tackle these translation problems which have not yet been solved. So if we're going to tackle these issues and create models that bring together this wide range of variables, the first question is, what is the data that we need and where can we find it? So I'm going to quickly run through the different types of data that are important for these models. So the first is probably adverse childhood experiences. So this is also known by a range of other terms, trauma and maltreatment, but they collectively refer to these events that were traumatic during childhood, which have got really negative and lasting effect on health. So you can see here the classic 10 that were identified by Felitti in 2009, and since then there's been a really widespread increase in the research in this area, and loads have been added, for example, bullying, experience of racial abuse and community violence, or even witnessing a dead body. And they're really common. So if we look at population surveys, more than half of the people have had experience of at least one, and 12.5% of people have had 4 or more. And when they look at the examination between ACEs and a range of disorders, we see this really nice and clear dose-response curve. And the magic number there is 4. So if a person's got 4 or more ACEs in their childhood, they were significantly more likely to suffer from a range of negative health and psychological outcomes. So you can see here a range of some of the more prevalent mental health ones. So for example, 4.5 times more likely to get depression and 14 times more likely to have suicide attempts. So the next question is, to what extent do they contribute to the burden of disease? Well, in children, they account for almost half of the risk of acquiring a mental health problem. So it's helpful, but it indicates that there's other factors contributing. So the environment alone does not account for the likelihood of developing a mental health problem. So the second kind of data is biological markers. Here you can see how the exposure to maltreatment is associated with corticostriatal limbic brain matter reductions in adolescents. Now, the literature is really rapidly evolving in this area, and we know that parental verbal abuse, witnessing domestic violence, sexual abuse all target specific brain regions and pathways that process and convey adverse experience. So you can see that we're really starting to develop this tangible map of biomarkers or endophenotypes, which are all really interesting candidates for the use of predictive models, which might help us identify how we can best identify the risk for mental health problems. Then the next type of data is information markers that also may be useful. So there's absolutely no causal mechanism that's been established to date, but we can say that for some people, so you can see here depression, autism, PTSD, and here's some candidate markers. But for some people with certain mental health problems, we're more likely to see these factors, so they're increased in the little red boxes. And again, so we're seeing these another category of kind of helpful predictors with potential value for modelling. And then finally, interestingly, what is the role of genomics? So we know that mental health problems are polygenic. Their influence from genetics involves thousands of DNA variants spread across the genome, each of which has got a really small influence on risk, but collectively can indicate vulnerability to mental health problems. So if we look at 2 examples, depression and schizophrenia, the current estimates are that the variants is explained only by 11%, and 4% of the variance is explained by polygenic risk scores. So it's a really small amount. However, excitingly, it provides a means to stratify the population. So if we look at individuals with depression and just look at the top 1% of risk, those young people have about twice the likelihood of developing depression in their lifetime compared to people who have much lower polygenic risk scores. So the problem here, though, is that there's real problems with these scores at the moment in terms of the methodology, which means that they're not currently fulfilling their potential and we can't use them for clinical services. So one is highlighted here in this figure. So you can see Owl et al. Illustrated just this year that in over a study that looked at 1 million polygenic risk scores in 1 million people, when they looked at GWAS for depression, they said there's very, very little specificity for those polygenic risk scores. So there was around 95 to 99% overlap between the variants that contribute to the risk of depression and other key mental health problems. So the reason for this is that the phenotyping or the description of the disorders that we have on cohorts is really heterogeneous and poor quality. So we don't have accurate enough information to create these accurate GWAS scores, and therefore we don't have accurate enough polygenic risk scores for prediction. And the other thing that's really problematic is that the lack of generalizability to people with different genetic heritage. So currently, biobanks have got 90% white EU, and due to differences in expression patterns between different ethnicities, that means that the current GWAS and polygenic risk scores created in those cohorts are just not useful at all in their current format for non-white EU, people of non-white EU descent. And so it's absolutely critical that we create these diverse cohorts of people contributing genetics for research of a sufficient size so that we can urgently address this. So at the moment, it's absolutely impossible to create predictive tools using genomic data for anyone that's not of the same, representative heritage of those in these cohorts. So this is clearly a critical ethical issue and something that needs to be really urgently addressed. So in addressing these issues and making access to data sets which include these broad range of risk factors, access as far as possible from routinely collected information is going to be really critical so that we can build tools which have got clinical application. So we currently don't have access to data sets like this in relation to children, which is where this project comes in. So how are we addressing this? Well, by using AI and machine learning to drive these clinical pathways will be a really radical change to how we do things currently. And so therefore, there are a really wide range of ethical issues that need to be addressed. We need to be transparent. We need to understand acceptability of the approach of the public. Also, we need to understand the impacts on clinical pathways and the role of professionals. There's a really ethical imperative for the consideration of potential harm as well, in particular for those from underserved groups. So we know that those from underserved groups suffer the most from data poverty. And so there's real potential for data-driven solutions to exacerbate or bake in inequality if we're not thoughtful about this. So to support this, we've recently launched Caring, which is a growing community now of over 200 people. And it's called the Child and Adolescent Research Involvement for the Next Generation. And it includes 11 to 24-year-olds and people who are parents and guardians, all of which are supporting this work to make our work more meaningful, but also to enable more meaningful involvement and engagement in paediatric research more generally. So they've been recruited nationally. We've worked with charities to make sure there's good representation from a really diverse set of backgrounds. Recruitment's ongoing. The group's involved along the entire backbone line of our work, how it's also designed to support paediatric research efforts more broadly from industry to academia. So the group manages recruitment, communication, safeguarding, support, training, facilitation for any PPI activities. And it's just literally launched this autumn. So if anyone does feel that they need support with their paediatric PPI work for research, innovation, industry or academic work, please get in touch. It's a funded resource from a range of organisations you can see there. So it's something that we're keen to get used. So you can see here a very quick slide that just illustrates the diversity of the group at the moment. So we're working with Anna Freud Centre to improve this, and we're selectively targeting recruitment to areas where we're less well represented. And this group has enabled us to support the foundations for the first regional linked shared data environment with population level data, which relates to close to all children in one area, CADRA. And that brings together data from health, education, social care, and it brings it together and linking it. And we can make this available now to researchers carrying out ethically approved research, and it's overseen by a data access committee. The infrastructure has also got capability to integrate genomic and other biomarker data, such as imaging in the future. And it's going to enable rapid access to a wide range of data that can be really easily incorporated into machine learning applications. So although it's been built to support machine learning and AI, it's got really widespread uses, including research, QI, quality improvement, and support of commissioning and more broader kind of health systems. So this is going to give a bit more detail of some of the components. Data is de-identified at source by validated open source software called Crate, transferred into CADRA at the moment via HTML protocols, but with Turing funding, we've adopted Crate to enable dynamic de-identification, which means we're moving towards real-time capability. Data is standardized with an integration engine called Intermine, a platform which can bring together diverse data types into a common data model. A critical aspect to CADRA has been information governance. So during 2022, we spent an entire year working with our cohort, as well as IG leads from each of the data providers, supported by information governance consultancy called IGS. And with their collective help, we've created the first ever data sharing agreement for pediatric linked data, which enables access to the data together with a framework that enables federation, which I'm going to talk about on the next slide. And these frameworks, I should say, are all completely freely available via either the HDR UK website, or please get in touch with me and we're happy to share them with you. Everything we've been doing is open source. So a really important principle has been the creation of an open source software, because a real key priority for this program has been to demonstrate that we can create cutting edge technology which tackles some of these big informatics challenges at a low cost in a sustainable way for the NHS and academia. So the final function for CADRA has been to enable privacy-preserving federated analytics. So through partnership with Bitfount, it's enabled us to bring together the ability to integrate these different data types across different geographies. So in the UK, we can't create these big data lakes due to IG constraints, but federation means that we can build AI models across different regions without having to access individual patient level data. And it means that data within each region remains local. The Bitfount pods we install have got multiple functions. So firstly, it means we can externally validate models in one region easily. So we can tackle some of those issues we talked about around limited variation and diversity within one region. Secondly, it means we can pool data sets mathematically to build data sets with big sample sizes, so we can tackle some of the issues around polygenic risk scores. And then finally, it means that we can allow access to industry to the data safely, because the data never gets seen at a patient level by industry, and they only ever get to see aggregated data. And that also means that they're able to protect their IP, which is one of the big barriers to organisations utilising healthcare data. So finally, we're looking to also incorporate genomics into our models. And to achieve this, we're recruiting the first ever recallable cohort of children who are willing to volunteer to participate in genetics research. And that's via NIH Bioresource. It's called Decipher, or the DNA Children and Young People's Health Resource. And we're going to be recruiting 12,000 young people who are consenting to provide their DNA sample. They do deep phenotyping, and they link their genomic and deep phenotyping data to health, education, and social care. So the recruitment is the first ever recruitment of children using a digital and remote approach. So parents consent online, children assent or agree to participate. They fill out digital questionnaires, and all of the sample provision is a spit sample, and it's all done by post. So although recruitment is open to any children, we've got a campaign which does focus on mental health to enrich the sample. And our approach is very much emphasised, heavily focuses on individual stories and people who are contributing, as well as a range of well-known media doctors and other celebrities who are contributing to it. We also have got a dedicated work stream looking at underserved groups, and so we'll be the first representative genomics cohort probably in the world. And so after 2 months, we've already had over 1,000 children and young people join, which is really exciting. So this autumn, we're going to be launching a big programme in schools to boost recruitment, in particular for underserved groups. And this resource is going to enable us to do some critical work around improving polygenic risk score accuracy, addressing some of the issue around generalisability by creating the first representative sample. And finally, it's going to let us explore the value of genomic data in these predictive tools for kids' mental health. But critically, both of these programs, CADRA and the clinical pathway Timely, are going to enable us to build the first ever pathway for personalised pathway for preventing child mental health problems. It's going to be based within Cambridge Children's Hospital and the Associated Research Institute, and that is the first ever genuinely integrated mental health physical hospital, which has got like shared care, social care and educational spaces. So here, through this programme, we're absolutely laying the foundation for the first system aimed to tackle the ongoing rise in prevalence of children's mental health problems. We're very much still at the beginning. There's loads of work to do to address the ethics, the evidence-based pathway redesign, introducing clinical genetics as part of our clinical pathways, and then understanding the implications that this approach will have for staffing in terms of skill mix and training. And further, we absolutely have to evaluate the approach, and in particular, with a focus on ensuring that we're not exacerbating inequalities for the most in need. So I'm going to leave it there. Thank you very much for listening for the talk. And if you have anything else you'd like to get interested to hear more about, so for example, either to get in touch about using caring or any of the open source approaches, or to hear about CADRA, the data set, which we're hoping will be available to the public, available to research programs next year, then please contact me on the email address here. Thank you very much.
Anna, thank you very much for a great presentation. It's wonderful to hear about the excellent work that you've been doing, and really the opportunities with data acquisition, data federation, and the multi-source of data that's been collected for future opportunities. So thank you once again, Anna.